All right, we'll get going. For those who don't know me, Calvin, don't go here anymore, used to, which is living proof that no matter how bad you are, you can still graduate. Um, we all make mistakes. All right, this is what we're going to talk about today, which actually is kind of interesting because we just went down, so now we'll go up. Did I work on this in the last like 5 hours because I can't sleep? Probably. Um, Little truth in advertising. I was actually roped into doing this 2 months ago when I was told that I'd be allowed to pick this off the shelf talk I've given like 4 times, and just like do it. But then 3 weeks ago, this guy had to publish a blog post, and then I had to scramble a little bit to figure it out. So we ended up with a different talk, which is why we're here. So I was trying to think about what it is that I could talk about instead, and then I was like, oh man, I haven't gone on any fun adventures recently. Then I remember I had out in the mountains about a year ago. So then I remembered that there used to be a certain Kings County attending who's actually not here at conference today, surprisingly, who had made the statement that Kings County Hospital was built on the highest point in Brooklyn. It's actually not true. It's just something that he made up for some television cameras at one point. If you look at the flood tables of Brooklyn, which are very important for global warming, which is coming up, you can see that we are actually a little bit higher than the lower lying areas of our nice borough. Which actually it lines up if you ever go on a deep dive. The last ice age, the terminal moraine of a glacier actually ended right here. So it's actually that big hill where Eastern Parkway is that goes to the park. And then anyways, all this is to say is like the highest point in Brooklyn is actually Battle Point, which is in the cemetery, Greenwood Cemetery over here. It sits at about 216 feet above sea level. So definitely nowhere near enough to get altitude sickness from. Which then raises the question, why are we even talking about this? Well, it's because if any of you ever take your in-service exam or you get ready for your boards and you have a patient who's going up to altitude and for whatever reason starts having any of these symptoms, headache, respiratory distress, lassitude, which is just a fancy word for being like out of it, weakness, ataxia, please by all means, for the love of Dr. G and Dr. Hassel, your board review team, just pick the answer to send. Okay, like that's it. You're done. If they're asking you what the definitive treatment is, just go down. Tell them to go down. Stop doing anything else. Just go downstairs. Okay. But if you're now thinking to yourself, wait, so there's only gonna be one question on this. There's like no environmental stuff on the boards or on in service. What are we supposed to talk about for the next 20 minutes? Well, in the interest of being a well-rounded emergency medicine doctor, people who know things, maybe you're lucky enough to have friends who aren't doctors, who come to you for doctor things because you're a doctor and so you'd like to know some doctor things. Maybe this could be helpful to you. But stopping with all the sarcasm for a second, there are some overlaps in the things that we're going to talk about today between altitude-related illness and some of the more common EM processes that you can run into in the emergency department without having to go to altitude. So we'll talk about how some of that interplays with each other. Take a moment here to pause. Who here has never left sea level? Okay, cool, good. So people from New York have like never left the city, and I find that wild ever since I moved here. Anyone ever not been above 4,000 feet? No, not travel. People not pay attention to these things. Has everyone not been above like 8,000 feet, which is kind of the cutoff where altitude sickness sort of starts? A rough estimate, what do you want in meters? All right, never mind. So this has worked out better in my head. Never mind, no more audience participation. All right, so this is kind of where most of the disease processes related to altitude come from, right? So when you're at sea level up here on the top, nicely written here in meters and feet for those of us imperial people, your oxygen saturation, or oxygen, I should say, relative oxygen concentration is about 20%. It's the same throughout the entire atmosphere. The only difference is as you go up, if you remember physics, the partial pressures of all gases goes down to the point that when you get to a place like, let's say, the summit of Mount Whitney at about 14,500 feet, you're working with almost a little bit more than half of what you had at sea level, which is where you start to run into problems. You can kind of see highlighted in the yellow there, yellow to orange is kind of where we start seeing altitude sickness. A lot of the literature will quote about 2 to 3,000 meters as being where you should really start thinking about it. Below that probably is not what's going on. Your patient's having a stroke. All right. So here's what we're going to talk about today. Just basically, there's 3 different disease processes. They sort of exist on a continuum, at least in the case of acute mountain sickness and high altitude cerebral edema. HAPE sort of, I put it below because it is related to altitude, but kind of does its own thing. There is obviously interplay between all of these. As you go higher, the risks of all of them go up. We'll also talk about the other things that increase your risk of developing these things. You also should be aware that there is obviously personal non-altitude related components to this, right? There's probably a genetic component to this. Not every person who goes to altitude develops altitude sickness. So it's actually important for you to know if you've ever been to altitude, if you've gotten problems before, chances are you may run into problems again. All right. So, just to point out, these pictures are from this cool trip I took about a year ago. Went to the Eastern Sierras. This was our little warm-up hike, which is up to Big Pine Lakes, which starts at about 7,900 feet, peaks at about 11,800. This was the like warm-up. So anyways, acute mountain sickness. This one is just basically a collection of symptoms. It's the things you think about. If you've ever been to altitude, when you start to have a headache, when you start to feel nauseous for no reason, when you're super tired and short of breath, that is acute mountain sickness. It's obviously related to the amount of hypoxia. Us here living at sea level, we are used to having our full complement of oxygen. As soon as that's taken away from you, life feels less good. There are other things to be aware of. So young age and being physically fit are not protective. That's actually borne out in studies. In fact, there's a reason that young men seem to be more susceptible to this. It's actually social. The advice is always start having these symptoms, you should turn around, stop doing what you're doing, go down, take a rest. And young dudes don't like doing it. Social determinants of health, whether or not they're internal or external. But in any case, you kind of can see that the one thing that actually does increase your risk, or at least a couple of them, are being a low level altitude resident. So us, right? If you start off living at sea level, your body's used to it. If you then use the wonders of the industrial age and find yourself at suddenly 8,000, 9,000 feet, probably going to have some problems. Obesity has been shown to be a risk factor, and then obviously the amount of exertion you're doing will play a direct role into your risk of developing it. That last point down at the bottom again, we're usually looking at this starting at elevations of about 2,000 meters. So the rest of the world uses meters. Sorry, guys. That's about 6,500 feet. Okay, which is, I don't know, floor, the level of your most favorite ski resort. Does that work? All right, cool. You're welcome. All right. We'll move on now to high altitude cerebral edema. So as mentioned previously, AMS and HACE sort of exist along the same spectrum. You can kind of think of it as you develop more and more hypoxia, start to develop cerebral edema in your head, and then bad things start to happen. By definition, HACE is any person who's suffering from acute mountain sickness and then starts to show neurologic signs. That can be anything from loss of coordination, it can be stroke symptoms, it can be basically loss of consciousness. You are now into the world of HACE, which is much, much worse. The symptoms, again, ataxia, last to confusion. The incidence is actually quite low, though. So you can go pretty far up into the mountains and never experience this. You can have really debilitating headaches. But as long as you're not like able to not touch your nose to or do that thing, you typically don't have HACE. There is this concomitant part. So I know that I said that it technically exists in a separate continuum than HAPE. However, you kind of think about if you start developing pulmonary edema, it's going to make your oxygen saturation drop. It's going to make it much harder for your body to oxygenate your vital organs, including your brain, and that's going to actually lead to more HACE. There is a time component to this as well. So you should be expecting to see this not before like 12 hours. So it takes a little while for that edema to build up in your head. So you shouldn't really start to have symptoms. If you're seeing things early, again, think other diagnoses, think stroke, think brain bleed, think, bad things. As far as the pathophysiology of this goes, it's likely, again, mediated by hypoxia. So as your body starts to see less oxygen around, your brain, as the most vital organ and the one that does all the thinking for you, just decides that it's going to try to get as much of the stuff as it can get. This leads to significant vasodilation. And you can kind of imagine that as you sort of vasodilate, you can start to distend things. You can start to have, if you remember, your head only fits CSF, brain, and blood, sort of increasing any one of those things, and you start feeling some squeeze. The pathophysiologic process is actually not perfectly understood. The theory is that, again, you have this hypoxia that leads to increased flow. You then develop some sort of cytotoxic edema, which then starts this cascade down into ionic edema, which then pulls more fluid out of the interstitial space and into the cells. And eventually it all just ruptures and your brain just becomes this mush. Some people who have survived HACE and been brought to a hospital actually have been shown to have reversible edema on T2 MRI. So it does support this theory that it's just an increased amount of fluid. Autopsies of people who died from HACE also show there may be a component of like microvascular hemorrhaging. So kind of sounds like a stroke, right? Like you cut off blood flow, like an ischemic stroke, excuse me. You cut off blood flow to your brain, hypoxia sets in, and then all of a sudden things start going bad, things rupture, things bleed, right? The only difference again is that you can fix this by going down or adding oxygen. But it does take time, unlike HAPE, which we'll talk about, to get a lot of that edema back out. So again, your pathophase here is increased blood-brain permeability, increased blood-brain barrier permeability, cytotoxic edema, then leading to more edema, then leading to ultimately death. I did run across something interesting when I was kind of reading up on this. There's a tight fit theory. The idea being that some people may have protection from HACE if they have less brain volume. All right. The last thing we're going to talk about is HAPE. So this is high altitude pulmonary edema. This is a version of non-cardiogenic pulmonary edema. We'll get into that in just a second. This is basically a disease process born out of the hypoxic ventilatory response, which is a fancy name for oxygen saturation goes down, you breathe faster. In this instance, your rest rate will go up, your vascular permeability increases, and if you do too much of that, you can kind of imagine you then start flowing some fluid into your alveoli where it's not supposed to be. This is actually of the, between this and HACE. HACE sounds worse because we all like our brains, but this is actually much more fatal. If you kind of imagine your ABCs, right, breathing. So if you can't breathe, you're probably gonna die. The disease process here is a little bit different than other sorts of non-cardiogenic pulmonary edema, again, just mediated by the fact that it's from hypoxia. So one of the things that can actually fix it quite quickly is by just giving supplemental oxygen. Very easy to do in a medical setting, a little more difficult to do if you're out in the wilderness. So it is something to consider. The symptoms you're looking for these patients are people, and again, it's hard because they start to mimic those of just being at altitude, right? So dyspnea, not being able to breathe, just having a slight cough, not being able to exert yourself. One of the hallmarks is that you go from being dyspnea on exertion to being dyspnea at rest. So you start feeling really short of breath, and all of a sudden you stop and you still can't catch your breath, and then you start coughing up pink sputum. Things are bad. All right. So as promised, we'll do a little bit of pathophys for this as well. This is a perfectly stolen image from the New England Journal of Medicine that describes different types of pulmonary edema. On the top, you have your normal lung. And on the bottom left, you have what it looks like in sort of cardiogenic pulmonary edema. So kind of think your CHF patients, right? You have a lot of blood flowing around. It then gets into the interstitium, then flows in, but it's mostly just fluid, not a lot of protein or other stuff in the interstitium of the alveoli. You zoom in on the part that we're thinking of, this is non-cardiogenic pulmonary edema. The problem here is that you, again, have your hypoxic ventilatory response that becomes disordered. You are no longer functioning in a physiologic state. This leads to pulmonary hypertension, again, very similar to something else that can cause pulmonary edema or flash pulmonary edema. The problem here is that because of the relative hypoxia, the vessels over here start to constrict in unequal places. So if you remember back to like day 2 of med school, right, laminar flow is very important in your blood vessels. Anything that disrupts that can cause shearing forces, can cause more damage, and eventually you break down your alveolar capillary interfaces, and then you just start dumping all your stuff into your alveolar spaces here. The good news, again, is that this is very rapidly reversible by introducing supplemental oxygen. You can basically relieve any of this hypoxia, right? So if you are able to provide supplemental oxygen, that can fix the patient. If you are able to walk them or carry them, say about anywhere from 150 to 1,000 feet, you should start to see some improvement. But carrying somebody who can't breathe sounds kind of difficult, especially because I weigh 135 pounds. All right. As far as assessing the risk of altitude illness, right? So a lot of times, we like to have a scoring system, your heart score, your NIH stroke scale. There is unfortunately not a good scoring system for altitude sickness in general. There's this, which is probably the most well-known. This is the Lake Louise symptom score. The problem with this is that this was actually only developed for researchers to decide who qualifies as mild, moderate, severe. So they made up the scoring system, and they said in their study that, oh, if you hit this number, this number, this number, we classify you as this. This actually has no bearing on how you're going to do in the real world. That being said, it's the only thing that we have. So The study it's based on basically just used 3 or more as their cutoff. If you hit 3 points, you had acute mountain sickness. If you didn't have it. Now, there are some places out there that you can see. The Wilderness Medical Society actually does not endorse this, but they say if you really want to, you can use 3 to 5 as mild, you can use 6 to 9 as moderate, and then anything above that would be considered severe. What does that mean? Who knows? The other thing is also not super helpful. This was another scoring system that came out of just, again, a research study. The AMSC, which is an acute mountain sickness clinical function score. As you can see, all the scores are in the past tense, which is to say that they had people go out in the wilderness and do the thing they're going to do, and then just ask them what score they thought they hit. Not, again, super helpful if you're just out in the wilderness trying to make things happen. There is something on the 2024 clinical practice guidelines released by the Wilderness Medical Society. This is really just for you to kind of think about if you're somebody who is about to go into altitude or potentially be like a medical professional and responsible for people going to altitude. It's a way for you to kind of score whether or not your risk is moderate, low, or high based on a couple of different things. So obviously, history of acute illness is very important. What elevation you're going to be sleeping at the first day. So if you go from obviously sea level to a much higher altitude all of a sudden, when you're sleeping, you're going to be spending a lot. That's when a majority of your time is going to be happening. And so that sort of is a good baseline for what altitude your body is seeing. And then your ascent rate, right? So how quickly you're going up and down from a place is going to determine how much risk you have. Their recommendations off of this is that if you fall into a moderate or high risk category for any of these, you should probably consider prophylaxis, and we'll get to that in a second. If you're a low risk, then you can probably forego it, but you may still have problems as far as just general acclimatization. All right, so that brings us to our last little bit here as far as the actual medical stuff, which is prevention and treatment. So does anyone know, I know I said no more audience participation, but I'll just risk it. Anyone know any medications that have been tried or recommended? Yes. Cetazolamide, very good. Does anyone know how or why it works? All right. Someone just has to like you with your chest. Come on. That's correct. So 5 points to whoever just said that. Yes, so acetazolamide works. It is a diuretic. So do remember, this is also a problem if you, again, take yourself out of the realm of just thinking about altitude sickness. Giving diuretics to patients who are exerting themselves is not a great idea, but it is something where it causes a metabolic acidosis by having your kidneys start to throw out, some of your bicarb. And then your body physiologically responds by creating a respiratory alkalosis by causing a relative tachypnea, right? So it has been shown that it can increase your acclimatization by a day, 2 days. You're supposed to start 3 to 4 days before you go. So it's actually like if you're planning on going to the mountains tomorrow, you're shit out of luck. If you're going over the weekend, now's the time to start taking your cetazolamide. All right. So this is the just another table I pulled off the WMS guidelines that were published again earlier this year. As you can see up top, acetazolamide and dexamethasone, which again, as we all know, very good glucocorticoid effect, use it to treat all our patients with their inflammations. Those are the two mainstays of treatments, the ones that have been studied the most, the ones that have been shown, at least clinically, to have some effect. The other thing here is that both of these medications can also both function in both prevention and treatment. The important delineation here is you'll see that under the treatment categories for both AMS and HACE, the doses tend to be just a touch higher or at least more frequent. And also, it is important to point out that the recommendations are that you use the treatment in order to facilitate descent, right? You don't get to start having HACE and then give yourself some medication and be like, I feel great, and then start going up. No, this is to get you feeling well enough that you can walk your own self down the mountain, and then try again in like a day or two, okay? There's a couple other things on here. Ibuprofen has been shown just to be a little bit better than Tylenol. Again, probably relates to the anti-inflammatory effect. Nifedipine is only recommended in people who have a history of HAPE. So if you have been to the altitude before and you develop pulmonary edema and you're like, dang, that was fun, we should do that again, that's for you. So that's the prevention and treatment, okay? The last two, tadalafil and sildenafil, depending on what kind of lifestyle choices you're into, were actually developed for pulmonary hypertension in the first place. So it does make sense that they have some effect. They have other side effects that you may not want, but they are there and they have been shown to work. You're welcome. All right, so that takes us through most of the medical stuff. Any questions? All right, I'll just reward you with pictures then. So anyways, on day 4, so we actually did it kind of right. We drove from Los Angeles to the Eastern Sierras. The problem is the Owens Valley where we're camping out is only at 4,000 feet. So the hikes were a little bit higher. Anyways, on the 4th night, we set out from the trailhead at Mount Whitney. Has anyone ever done this hike? Oh, nice, Galena. Nice, makes sense. Bam. So we actually started out at about 1:30 in the morning. And the problem with that is that there's just not a lot of pictures from this time because there's not a lot to see. It's like try to take some pictures. Yeah, there's stars. Yeah, it's not a lot of stuff around. But eventually you kind of get up to this point, which is where the switchback starts. So there's a very famous part of this hike where you just go up 99 switchbacks. It's about 4.5 miles into the hike. So at this point, it takes about 2.2 miles to go up 1,800 feet. And then you crest at Trail Crest, which is where the Whitney Trail meets the John Muir Trail. Kind of a famous point. But then eventually the sun comes up, things look nice over the mountains. The problem for us is that California is actually no longer in a drought, despite what you might have heard. So this year there was a ton of snow still in September, which made it very kind of difficult going. This is Trail Crest. So this is about 13,600 feet, roughly, thereabout. And this is where headaches and other things started to kick in. And I was like, dang, this kind of sucks. We did eventually make it though. So you have to traverse here kind of across this ridge, which is really annoying and very rocky. We did make it the last 2 miles or so, repping my awesome Kings County fleece because I definitely thought it was not going to be that cold. So I've been wearing about 3 other shirt layers underneath that. But anyways, yeah. So I highly recommend if you're into it. It's very walkable as long as you're healthy and can have like 2 legs, or you need 2 legs as long as you can walk. You could probably do it. You don't have to walk. Any case, take home points. All right. So no matter what, again, please, 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 the answer on the test is descend. Okay. As long as you get that, everyone is happy and you've gotten your 1 environmental question correct. Okay. The other take home points. Okay. So remember, it's related to elevation and your rate of ascent, right? So as you go higher up, the risk increases. As you increase your hiking duration, or at least how quickly you're ascending, that will also increase your risk. So Whitney starts off at like 8,100 feet and peaks at 14,500. So yeah, people run into some problems sometimes. Again, remember that unlike their sort of more medical counterparts, the pathophysiologic changes related to HACE and to HAPE are both pretty rapidly reversible, with the mainstay being to descend, right? The caveat there that you can, at least with HAPE, give your patient supplemental oxygen if you happen to have it with you. So if you are, say, the medical director of a excursion or an expedition, if you're carrying someone with you, that should be able to fix their pink frothy cough very quickly. And the last point there is, again, that pharmacotherapies do exist. So if you are somebody who is interested in going to the mountains or have friends asking about going to the mountains, you actually just need your NPI number and the person's birth date and name in order to prescribe them things. You can, acetazolamide is pretty easy, pretty well studied, quite safe. You do have to be careful if you're mixing it with other things that dehydrate you, alcohol, that, it can run into problems that are besides that. And then also remember, think about, just because you're at altitude doesn't mean that your patient can't have other things. You can have a stroke at 14,000 feet. It's entirely possible. It just is a little bit less likely than, well, I guess not less likely. There are other things that can cause. All right, so that's kind of it. As the customary ending, shout out to the best class. I had to pick this candid picture because Miguel kept trying to hide in all the pictures. So he's right there. And then Ryan's making San Diego white person gang signs, which is awesome. And then I realized that someone was missing from this, and it's Jane. So I had to add her here because she had just had her kid. And then we claimed these people too, like, the EMIMs, they're cool. And then obviously family.